Here at CHEST 2015 in Montreal, Thomas Baldrick along with Dr. Patty George from the University of Pittsburgh Medical Center. Thanks for spending a couple moments with us.
Thank you for having me.
You work on patients both pre and post-transplant. What are the risk factors that determine when a patient should have a lung transplant?
So in general, in all patients, transplant is considered, a treatment of last resort, obviously, for patients with any lung disease. So when patients with any lung disease are developing worsening of their disease despite maximal medical therapy, hopefully long before they're at their last phase of their disease, they should be referred for transplant. So when they start to worsen, medical therapies aren't working, it's really time to refer people for transplant. In pulmonary arterial hypertension specifically, again, we're really looking to see people when they've perhaps started medical therapy and are still worsening. So we look a lot and we talk a lot about trajectory of disease. A lot has changed since the early 80s, before we even had effective medical therapies for transplant. And now we have the luxury of, with 12 FDA-approved medications on the market, we have the luxury of actually initiating someone on medical therapy and seeing how they respond before we talk about transplant. Whereas back in the day, that was the only treatment. But nonetheless, unfortunately, pulmonary hypertension still is a chronic medical condition and there's no cure. And if you look at papers, there's still a projected 65% survival at 5 years. So we definitely want to see people if they're progressing in their illness despite medical therapy.
Let's talk about the timing of referral when it comes to a lung transplant.
Yeah, absolutely. As has been mentioned many times, when patients get to a point where medical therapy really isn't benefiting them or they're worsening on current therapy, or in the case of pulmonary arterial hypertension, when they're started on an IV therapy specifically, despite what we call functional classes, we really hope that would be a time that referring providers would refer them for lung transplant evaluation. Oftentimes patients are very hesitant to undergo lung transplant evaluation, and sometimes providers are hesitant to refer because they think lung transplant is the treatment of last resort. But the truth of the matter is, lung transplantation requires extensive evaluation, medical evaluation, and education of the patient. Oftentimes in that 3 to 5 day evaluation period of visits with numerous doctors, a whole myriad of testing, we'll even uncover things that the patients may not have known existed, whether it's a medical condition that needs to be addressed or assessed, or a disease they may already have, like diabetes or obesity, that we really have to come up with an aggressive plan to address and improve upon so that they can be a candidate for transplant. And so it's really important that patients are referred even, I don't think you can ever say too early, but that they're referred earlier rather than too late for transplant.
How much have the new therapies changed the landscape in how you treat PAH, and how much more of the void needs to be filled?
Oh, great question. Certainly the therapies have changed the landscape, as well as how we employ those therapies. With recent studies coming up supporting aggressive upfront therapy and dual combination therapies in PAH, we certainly, fortunately, have seen improvements. If you look at predicted survival data from 10, 15, 20 years ago compared to now, we've definitely made some improvements. But yet again, there has to be a lot more there's still a lot more to be done. With a 65% 5-year predicted survival based on analyses of the Reveal cohorts, we still have a long ways to go.
You were involved in the session here earlier at CHEST on non-pharmacologic treatments. How important is it looking at way beyond the diagnosis and treating the entire patient?
Oh, it's so important. Of course, the greatest levels of evidence are in our randomized controlled trials, which help guide our medical treatments. But at the end of the day, we're faced with a whole patient sitting in front of us. And our goal is not just to get them to a defined endpoint of being on 2 medications, 3 medications to achieve X outcome. Our point is to help normalize their lives and help them be able to live their lives. So that includes things like managing and treating anxiety and depression. That includes helping them be able to exercise and enjoy physical activity. It includes helping them be able to do things like take plane flights and other things that are just part of hopefully living a joyous life.
In your experience, how would you share with your colleagues what a PAH diagnosis means to the quality of life of a patient?
From talking with many patients, both my own and people in the PH community, getting diagnosed with pulmonary arterial hypertension, it changes people's lives. They are diagnosed with a chronic medical condition that has treatments, still no cure. When they get started on therapy, patients aren't sure if they're going to be a responder or a non-responder to therapy. There's a lot that goes into that. But no matter what, everybody's lives, when they get that diagnosis, they do change. So it's important for us to really be our patients' best advocates, both in helping achieve an early diagnosis as early as possible and hopefully early treatment, and also helping them cope with having this chronic medical condition.
Thank you, Dr. George. Appreciate your time. Keep up the good work.
You're welcome. Thank you.